So Abraham Lincoln, right? He
Oh.
he guided a nation through its bloodiest, just most fracturing conflict, operating at this absolute highest level of strategic leadership.
Truly unprecedented pressure.
Right. But if you read the letters and, diaries of his closest friends, you don't actually find descriptions of this stoic, unflappable commander. You find descriptions of a man who lived under a relentless, just unshakable cloud of misery.
Yeah, a really profound misery.
Exactly. A man carrying a psychological weight so heavy that his law partner actually noted that melancholy just dripped from him as he walked, which is such a vivid image.
It really is.
So today, for everyone listening, we aren't talking about a sudden catastrophic depressive crash. We are talking about the permanent gray winter sky of persistent depressive disorder, or PDD. Welcome to the deep dive.
Glad to be here.
We've got a massive stack of historical case studies, diagnostic research, and clinical trial data today, and our mission is to explore for you what it actually means to live with a long-lasting low mood, and crucially, how the underlying mechanics of this chronic condition completely separate it from acute major depression.
And that is a really critical distinction to make, especially for anyone listening who wants a clearer, more accurate understanding of mental health. Because, we tend to conceptualize depression as an event, like a crisis that incapacitates someone for a few months.
Right, like a bad episode.
Exactly. But PDD operates on a fundamentally different timeline and really a different physiological mechanism. We are looking at a persistent underlying low mood that stretches on for years, I mean, often decades.
Decades, wow.
Yeah, it reshapes a person's entire baseline reality. They don't just feel sad. Their cognitive and biological systems actually adapt to this constant state of depletion.
Okay, let's unpack this. Because looking at our sources, to understand how modern medicine tackles a condition this entrenched, we actually have to look at the historical friction of how it was first identified.
Right, do, yeah. It goes way back.
Right. The terminology starts in the 19th century with a German psychiatrist, Karl Kalbaum. He introduces this term dysthymia. But back then, what kind of resistance was he facing? I mean, the medical community in the 1800s wasn't exactly known for its nuanced grasp of mood disorders.
No, they absolutely were not. In Kalbaum's era, psychiatry was largely divided into two very blunt categories.
Like just crazy or not crazy.
Sort of, yeah. You had institutional asylum madness, so severe psychosis, mania, complete detachments from reality. And then on the other end, you just had this vague nervous exhaustion or like temperamental flaws.
Ah, gotcha.
What's fascinating here is that Kalbaum's methodology was entirely radical for the time. He wasn't just looking at a cross-section of a patient's current symptoms. He was actually observing the longitudinal course of the illness.
So tracking them over time.
Yes, exactly.
Yeah.
He recognized a subset of patients who weren't experiencing catastrophic psychotic breaks, but rather a chronic, unyielding, melancholic state that just never lifted.
But I'm guessing the other doctors didn't just accept that right away.
Oh, the friction he faced was immense. The medical establishment essentially viewed this chronic low mood as a moral failing. They literally labeled it a depressive personality.
Wow. So they thought it was just a character defect, like a lack of willpower.
Exactly. It wasn't seen as a physiological pathology. It was just, who you were. So Kalbaum's introduction of dysthymia was this major attempt to drag this specific type of suffering out of the realm of theology or philosophy and plant it firmly in clinical medicine.
Making it a real medical issue.
Right. He was arguing that just because a condition doesn't present with explosive visible symptoms, that doesn't mean it isn't a systemic disease.
I really like the analogy of comparing major depression to this violent passing hurricane, right? It wrecks everything, but it passes. While PDD is like that permanent gray winter sky that someone like Abraham Lincoln might have lived under every single day.
That's a great way to visualize it.
But which brings us back to Lincoln, who is heavily documented in our sources today as this archetypal case study for PDD. I have to be honest, though, I always carry a healthy amount of skepticism when modern psychiatrists try to retroactively diagnose historical figures.
Sure, it can be tricky.
Right, because aren't we just pathologizing a guy who had a remarkably stressful life? I mean, the man led a country through a civil war. He buried multiple children. Anyone would be profoundly depressed. How do we know this was a clinical persistent disorder and not just, a very logical reaction to a really tragic life?
It's a very fair skepticism to have, for sure. Context matters immensely. However, when clinical historians analyze the Lincoln data, they aren't just looking at his mood during the Civil War.
We're looking further back.
Right. They're looking at his entire adult life. The profound psychomotor slowing, the pervasive anhedonia, which is the inability to feel pleasure, and the chronic sleep disturbances. These were all documented well before his presidency.
Oh, really?
Yes, well before his children died and well before the war. It was his baseline in his 20s and 30s as a circuit lawyer.
Wow, okay. That changes things.
It really does. And the fact that he functions so highly despite this baseline, it completely shatters the myth that chronic depression equates to incompetence. But it also highlights the sheer, almost unimaginable endurance required to operate a brain that is literally fighting against itself every single day.
Man, and realizing that millions of people are walking around today operating under that same heavy baseline naturally forces us to look at how modern medicine actually classifies this, because for you, the listener, navigating the system today requires a highly specific vocabulary.
It really does. It's a whole different language.
Yeah, and the sources track a major evolution in the DSM, the Diagnostic and Statistical Manual of Mental Disorders. In DSM-3, which was published in 1980, they formalize Kalbaum's idea. They call it dystemic disorder, and they mandate a very specific metric, right? To get the diagnosis, a patient must exhibit a depressed mood for most of the day, for more days than not, for at least 2 solid years.
Yes. That 2-year marker became the absolute defining characteristic, separating it from an acute major depressive episode, which, by the way, only requires a 2-week duration of symptoms for diagnosis.
As I struggle with this DSM timeline, if a doctor demands a patient suffer for a full 2 years just to get the specific diagnosis, aren't we just withholding targeted treatment while we wait for some arbitrary clock to run out on a calendar?
I know, on an individual patient-to-doctor level, it sounds incredibly counterintuitive, almost cruel, really.
Yeah, exactly.
So you have to understand what DSM-3 was trying to accomplish macroscopically. Prior to 1980, psychiatry was deeply, deeply entangled in psychoanalytic theory.
Like Freud and all that.
Yeah, right. Diagnoses were often based on a doctor's subjective interpretation of a patient's unconscious hidden traumas. But chronic persistent depression often lacks a singular, explosive, inciting trauma. It's a slow, grinding burn.
Right. It's just always there.
Exactly. So DSM-3 shifted the entire field toward observable, measurable, empirical data. They needed a concrete timeline, 2 years to build a research cohort. They needed a standardized way to study what chronicity actually does to the human body over time.
So what does this all mean for the patient in the long run? Because the manual keeps changing, right? Our notes show that by the time we get to DSM-5 in 2013, they completely merge the old dysthymia diagnosis with chronic major depressive episode.
Yes, they did.
They lump them together into this new umbrella term, persistent depressive disorder. Why merge them after doing all that work to separate them?
Because of the longitudinal data that researchers were finally able to gather, thanks to that strict DSM-3 criteria. By tracking thousands of patients over decades, they discovered something that completely upended previous assumptions.
What did they find?
They found that the duration of the depression is actually a much stronger predictor of long-term morbidity than the acute intensity of the symptoms.
Wait, really? The length matters more than how bad it gets?
Yes. Whether you have a mild depression that lasts for 5 years or a severe depression that lasts for 5 years, the chronicity itself is what wires the brain for failure. It damages the cardiovascular system, it degrades cognitive function, and it erodes social support structures.
So it's just grinding you down.
Exactly. By merging them in DSM-5, the psychiatric community was sending a definitive message. Chronicity is the true danger. It is not a late version of depression.
And there is a fatal flaw in relying on that 2-year timeline as a measure of stability, isn't there? It implies that if a patient just stays at that low baseline, they're managing, they're surviving.
But they're really not.
Right, because our sources highlight the research of Martin Keller and Robert Shapiro in the early 1980s, and their work completely shatters that illusion. They documented the phenomenon of double depression.
A terrifying concept, honestly.
Yeah. Here's where it gets really interesting. This is what happens when a patient living with that chronic baseline of PDD suddenly experiences a severe, acute, major depressive episode right on top of it.
Exactly. Prior to Keller and Shapiro, there was this dangerous assumption in the medical community that chronic dysthymia might actually inoculate a patient against severe crashes.
Like they were used to it.
Right. The logic was, if your mood is permanently flattened, you don't have far to fall.
You can't fall off the floor.
Right. But Keller and Shapiro proved that not only can you fall through the floor, but the impact is catastrophic.
If PDD is like treading water in a freezing ocean, double depression sounds like someone suddenly tying a heavy weight to your ankle. How does a clinician even begin to untangle two overlapping conditions like that?
Well, to understand why it's so heavy, you have to look at the neurobiology of what chronic depression actually does. Living with PDD isn't just an emotional state. It is a state of chronic physiological stress.
It's physical.
Very physical. It keeps the body's stress response, the HPA axis, constantly activated. Over years, this chronic cortisol exposure downregulates a crucial protein in the brain called BDNF, brain-derived neurotrophic factor.
Okay, BDNF. What exactly does that protein do?
Think of BDNF as the fertilizer for your brain. It promotes neuroplasticity, the ability of your brain to grow new connections, adapt to stress, and learn new ways of coping.
Okay, so it helps you adapt.
Right. But when you have PDD for years, your BDNF levels just plummet. Your brain literally loses its physical ability to adapt to new stressors.
So to use an analogy, think of a brain with PDD like a smartphone with a severely degraded, just ruined battery, right? It never charges past 15%.
I have that.
It can handle basic background tasks barely, but double depression is what happens when a major life crisis hits, like a job loss, a divorce, a death in the family, and you try to run a high-power, intense app on that degraded phone.
It crashes.
Exactly. The system doesn't just slow down, the screen goes black. The phone completely shuts off because there was absolutely no reserve power to handle the spike in demand.
That is precisely what is happening on a biological and psychological level. If we connect this to the bigger picture, Keller and Shapiro showed that patients with double depression face significantly higher rates of hospitalization, severe functional impairment, and suicidality than those with major depression alone.
That's horrifying.
It is. The patient's resilience is utterly bankrupt before the major episode even hits.
Which explains why standard treatments historically just bounced right off these patients. I mean, if the brain has been marinating in stress hormones for a decade and neuroplasticity is practically zero, you can't just throw a standard 6-week talk therapy protocol at them and expect a cure.
You can't. And for a long time, standard monotherapies using just one standard SSRI antidepressant or just utilizing standard unstructured therapy yielded abysmal relapse rates for chronic depression.
Because it wasn't enough.
Right. The medical community was incredibly frustrated in the late 90s because this demographic was considered notoriously treatment-resistant.
Which brings us to the centerpiece of our research today, the pivot point. Our notes highlight a massive foundational clinical trial published in the New England Journal of Medicine, the NEJM, in the year 2000. Now, with all the medical advancements we read about daily, why does a specific clinical trial from the year 2000 remain such a foundational pillar in our research notes today?
This raises an important question about the mechanisms of psychiatric treatment. The 2000 NEJM trial, which was actually spearheaded by Martin Keller, the same researcher who identified double depression.
Oh, wow, full circle.
Yeah, exactly. It remains foundational because it didn't just test a new drug. It tested a highly specific integrated mechanical approach to the exact physiological and psychological deficits we've been discussing.
Okay, so what did they actually do?
They took a large cohort of chronically depressed patients and split them into 3 groups. Group 1 received an antidepressant medication called nefazodone. Group 2 received a highly specialized therapy called CBASP, the Cognitive Behavioral Analysis System of Psychotherapy.
And the third group?
And Group 3 received both combined.
Okay, let's break down the mechanics here, starting with the drug. Why nefazodone? Why not just a standard SSRI like Prozac that everyone has heard of?
Nefazodone is different. It's a SARI, a serotonin antagonist, and reuptake inhibitor. Without getting bogged down in too much neurochemistry, standard SSRIs can sometimes cause emotional blunting or actually exacerbate lethargy in chronic patients.
Making them more tired.
Right. But nefazodone modulates both serotonin and norepinephrine pathways in a way that specifically targets the profound psychomotor retardation and the chronic sleep architectures that are so disrupted in PDD without numbing the patient entirely.
So it targets the physical energy deficit.
Yes, exactly.
Got it. It starts repairing that degraded battery we talked about. But what about the therapy side? Group 2 got CBASP. What makes this so different from standard therapy? When I read the acronym Cognitive Behavioral Analysis System of Psychotherapy, it just sounds like jargon. How does it actually work in the room?
I know it's a mouthful. But CBASP is entirely unique because it was developed specifically for chronic depression by a psychologist named James McCullough. When a person is depressed for a decade, they develop what McCullough called pre-operational thinking.
What does that mean?
They lose the cognitive ability to see how their own behavior affects other people. They feel entirely disconnected from their environment, like victims of circumstance.
Oh, interesting.
So standard therapy often asks patients to explore their feelings or childhood traumas, which a chronically depressed patient will just ruminate on endlessly without actually changing anything.
They just spin their wheels.
Exactly. CB8AP stops the spinning. It is highly structured. It forces the patient to perform situational analysis.
How does that look in practice?
The therapist has the patient take one specific recent interpersonal interaction, say a fight with a spouse. They have to map out exactly what their desired outcome was, what their actual behavior was, and precisely where the disconnect happened.
Oh, wow. So it's very logical.
Very. It mechanically teaches the patient to see cause and effect again. It shows them how their chronic withdrawal and hostility are physically causing others to pull away, which just reinforces their depression. It forces them to break that feedback loop.
That sounds incredibly intense. I mean, you are essentially asking a patient whose brain is already depleted to do heavy, uncomfortable cognitive lifting.
Which is exactly why the results of the third group in the NEJM trial are so legendary. Let's look at the numbers.
Okay, hit me.
Group 1, the nifazodone medication alone saw about a 55% response rate. Group 2, the CBASP therapy alone saw a 52% response rate.
Right, so logically, as a layman looking at this, you'd think combining them might bump you up a little bit. Maybe you catch a few extra patients who didn't respond to one or the other, pushing the success rate to like 60 or 65%. Why did the combined groups skyrocket to an 85% response rate? What is the mechanism of that synergy?
The mechanism is neuroplasticity meeting targeted cognitive restructuring. The combination didn't just add together, it multiplied.
Wow.
The nifazodone provided the biological energy. By modulating those neurotransmitters, the medication began to restore the BDNF levels we talked about earlier.
The brain fertilizer.
Exactly. It reopened the brain's physical capacity to learn and adapt. It gave the patient the actual bandwidth, the battery power, to tolerate the intense, uncomfortable work of CBASA.
Ah, I see. The medication builds the hardware capacity so the therapy can install the new software?
That is the perfect way to phrase it. If you just give the therapy, the patient doesn't have the biological energy to implement it. If you just give the drug, you give them energy. But they still have decades of ingrained destructive behavioral patterns that they will just repeat with more energy.
Which doesn't help at all.
No.
Yeah.
So the 2000 NEJM trial proved that for chronic entrenched depression, biology and psychology are inextricably linked. You have to attack both simultaneously. It set the gold standard that remains today. Chronic conditions require integrated mechanistic treatments.
That is just a phenomenal breakthrough to unpack. It completely shifts the narrative from, enduring a permanent gray sky to actively building a weather machine to clear it.
It really does. It brings hope back into the equation.
Absolutely. So let's take a step back and look at the whole map of what we've covered for you today. We started by looking at how Carl Kalbaum fought the 19th century medical establishment to classify dysthymia as a legitimate physiological course of illness, not just a moral failing. We looked at Abraham Lincoln's lifelong struggle, proving that this profound baseline of suffering is not just some modern invention. And we dug into the rigorous, data-driven evolution of the DSM, understanding why researchers demanded longitudinal metrics to finally prove, in DSM-5, that chronicity itself is the true danger of persistent depressive disorder.
We also explored the physiological and psychological collapse that happens during double depression, as mapped by Keller and Shapiro, showing how a depleted HPA axis leaves the brain entirely vulnerable to acute crises.
And finally, we broke down the mechanics of the landmark 2000 NEJM clinical trial, proving that the precise synergy of biological intervention like nifazodone and highly structured behavioral analysis like CBASP can completely rewire a brain that has been stuck in a depressive loop for decades.
And as we close this deep dive, there is one final larger implication to consider here. We spent time retroactively applying these specific clinical insights to Abraham Lincoln. We understand his enduring melancholy not as a personality trait, but as an entrenched disorder that he fought daily.
Yeah, daily battle.
But it forces a wider historical question for you to think about. How many other monumental historical decisions, how many paradigm-shifting scientific discoveries or massive political movements were silently shaped by leaders, artists, and thinkers who were unknowingly navigating the cognitive drain of an undiagnosed, persistent low mood?
It's incredible to think about. How much of our built world was constructed by people operating on 15% battery?
And more importantly, how fundamentally different might human history have played out if those same individuals had access to the precise clinical vocabulary, the neurobiological insights, and the integrated treatments that finally cracked the code in trials like the one in 2000.
It totally recontextualizes the past, and I think it demands that we look at the quiet, chronic struggles of the people around us right now with a lot more scientific empathy. Thank you for taking this deep dive with us today. Keep questioning the baseline, and we will catch you on the next one.